Good morning to everybody that has hopped on with us. Thank you for joining. We're going to give a few more minutes for folks to hop on. I'm Reed Plimpton, if we have not met. I'm the project manager for the Northeast Telehealth Resource Center, and I'll be your moderator for this session, which effectively means I'll be talking for about 2 more minutes, and then I'll be handing it over to our wonderful presenters and the information that they have to share today. I have used the Zoom chat to provide the link back to the platform facing question section. And so the questions are actually going to live within the platform, both so all attendees can see them, but also so that, like the plenary sessions, they can be upvoted if necessary. And so please do try to read through and upvote so that I know if there's similar questions or if somebody would definitely like topic discussed. Otherwise, I hope you guys took the plenary to kind of get used to the platform, and I'll be available in the webinar chat and within the platform to assist you if you have any needs. With that in mind, I do want to be very cognizant of their time, and I want you all to hear the wonderful information they have to share. So it's my pleasure to introduce Maureen Donovan and David Robinson of Athol Hospital to talk with you today about telebehavioral health counseling programs in rural high schools.
Hey, good morning, everyone. I'm very, very excited to be here. I'm really thrilled. Thank you, the NETRC and the Mid-Atlantic TRC, for inviting David and I today to be here. We're going to be using a PowerPoint presentation, but I'm known for not necessarily following everything on that. It's a guide. I won't be reading from it. I just want to talk to you about our programs and let you know what we're all about. We're very proud of it, and we're ready to share with you. Our first slide, the next slide, will be a video of our program. There's one caveat though, that we are a HRSA funded program right now, and some of us in 2 of our schools, but this video was made with one of our schools that is not receiving HRSA funding. And I say that because it was a film made to lobby for telemedicine parity in the state and to pass a telemedicine bill at the State House. So I just want to say that before we watch it, and now we're going to watch it and we'll move forward.
Telebehavioral school-based counseling program is a program that we've put together in 3 of our regional high schools that allows students to get behavioral health counseling during the school day with our clinicians who are located off-site. The genesis of the telebehavioral health program really began with our focus on the social determinants of health in our region. As a rural region in the state, we have limited access to resources, especially when it comes to behavioral health, and even more so when it comes to dealing with children and adolescents, getting them access.
Kind of a support system for the students. They come in every day and check in with me, and then I set them up for their therapy session with Amy.
I provide remote counseling via the program Zoom to students at Narragansett High School and middle school. So students have a 45-minute session scheduled every week, just as they would with a clinician through an agency or private practice. You have a lot of students referred for anxiety, care-related issues, self-esteem issues, past trauma or current trauma. We have our 45-minute session. We talk a lot about coping skills, about tools they can use to get through the school day, tools they can use at home.
Well, the results is that we're full. 28 students currently. We have certainly seen that pay off tenfold with the quality of care that we're receiving with our community health worker, the clinician. Kids are wanting to go to counseling. This has been a huge success here, and I'm just so happy for the kids and the families who've been able to benefit from it.
I think it's important because there are so many families we work with that don't necessarily have transportation. So having it available when the child's already in school, it has been huge.
Now that they're actually being able to receive counseling right here in the school building, they're better prepared to learn. Their attendance is better, their grades are better, their relationships in a lot of cases are better.
The outcomes we have seen are incredible, really fantastic work is being done. Telebehavioral health services are just a natural extension of the work that we've been doing in the community. But to make it sustainable and not rely on successive rounds of grant funding that are tenuous to receive, I feel that we really need to put forward and advance the legislation that's on Beacon Hill right now that requires parity by all payers for reimbursement for telebehavioral health services, which we have shown in our short tenure providing those services is to be wildly effective, not only with youth, but we know that it's effective with all age groups as well.
Okay, here we are at a program overview. So I just want to start to talk about what we do and how we're doing this and how exciting it is for us. I want to let you know where we are geographically located. We're in the North Quadrant. I'm not sure if you've ever seen any of those maps on Facebook, but if you did, this would where the dragons would be living. We're out in the middle of nowhere, pretty much between two very rural counties, Northern Worcester County and Franklin County. And we have 9 towns, Athol, Irving, New Salem, Orange, that have been, this whole area is pretty much deemed rural. So that's what's allowed us to be able to take advantage of rural grants around this area. Next slide, please. So why do we do this? This is 4 tenets of the program. I think they're very simplistic, and I know that, but it's because this is so easy to do. We are bringing access, we're allowing students to access behavioral health services in a school setting without life interruption. They come into the school, they're there already, they come down where there's a community health worker waiting for them in a space that's not marked. They come in, they meet with their clinician who is working from home remotely. They have their clinical session, checking in and checking out with the community health worker. Very simple, very seamless. And we're providing a great service to them. We're creating safety nets. The community health worker provides wraparound services. So if a family is having issues around food insecurity, or they can't heat their home, or they're having a domestic violence issue, they are working with the community health worker to work on those intrinsic family issues, as well as the student is receiving clinical services. It's seamless and simple. The school IT department is your best friend, and they are so supportive of putting this together for you. And you know, everyone's on a Chromebook, everyone's on, you know, this is just life for schools now, and especially post-COVID, which we're going to talk about as we move forward. And students like it. They're very it's very simple. They enjoy it. They're screenagers, right? They enjoy screens. They're comfortable with it, and they engage very, very well. So this is why we do this. And let's see the next slide, please. So how are we doing this? And we have to be very honest that this program probably wouldn't have been even possible if it weren't for the first funders that we had, the HPC, the Health Policy Commission, who gave us an 18-month pilot, a grant to pilot the program. Whenever you pilot a program, you know that there's great learning there, and you realize what a better model might be if you tweaked it here or tweaked it there, which is what we did when we applied for the HRSA grant. The HRSA Evidence-Based Telehealth Network Program grant, we received $1 million to implement this. We implemented in 2 rural school districts, Athol Regional School District and Maha Regional School District. And we also have 1 school that is funded via other monies, which I'm going to speak about in a second. And we also have a treatment as usual school. We also received a Blue Cross Blue Shield Foundation grant, and that grant allows us to expand into a family counseling program with one of our schools. We also have Schrift monies that bring services to rural areas to increase access. And we have started building sustainability by billing. We have a telehealth electronic medical record, a bill in Athena right now, and we're expanding to a different EMR for the hospital system in February, but we are actually seeing reimbursement and being able to look at, is this possibly sustainable for for our healthcare system. And in all honesty, it's looking real, and I'm very excited about that, because to be able to go from grants, you know, where you're relying on this, to an actual program is just absolutely amazing. And I'm trying to rein in my passion a little bit, but I am so proud of this program and I'm so excited about it. And also, we certified all our community health workers with the state of Massachusetts. At this point, it's not billable service right now, but I think Massachusetts is leaning that way. So we want to make sure all our community health workers are certified. Next slide, please. So this is just to focus on the HRSA grant a bit. I just want our partners are up there. We have we are charged with increasing access to behavioral health for 220 students. At this point, we've seen 164 students, so I think we're in really good track to meet that goal by providing school-based telehealth services. We need to prove the concept by using our schools that have implemented the program, as well as our treatment as usual school, and we have to prove sustainability through insurance reimbursements, which is the real focus of year 3 this year. Next slide. So I want to go over the process. There's going to be a lot of words here. I'm going to pre-warn you, and don't worry about it. I'm not going to go through every piece. I just want to talk about the general program and how we implement this. So next slide. So it starts with our school districts, and it starts with a good relationship with our school partners and developing that and having them embrace this program. That's a critical piece, top-down support from the superintendent straight through into the school. The referrals are made through the guidance department, but we have referrals from teachers, school psychologists, nurses, and then that guidance department will do a soft handoff, and we'll call the parent and say, you know, we have this behavioral health program supported here, and we love for your son or daughter to take part in this. And then it moves forward. The intake is done now virtually, and I'll talk a little bit about that post-COVID, but we complete the intake. Students over 18 can complete their own intake. Next slide. And so here's I just wanted to bring this slide up because I wanted you to see what it looks like in the school. We're a little different now since schools closed on March 16th, and we'll address that in a bit, but this is what it looks like. There's our wonderful clinician, Leslie, there. And this is the room. It's an unmarked room. A student comes in once a week, 45 minutes, usually during a class that's not as strenuous, we're not going to pull them out of, AP mathematics. If they have something that they can come out of that is less stressful, we don't want to create more stress. It's in a confidential space, and the student and the clinician, we use Zoom. Obviously, you're on it now. You see how fabulous Zoom is. The space has all sorts of things in it to keep the student's attention. The community health worker is never far away and texts with the clinician just in case anything is going not so well in the room. We're always on that. And then the student checks in and out with the community health worker. You're never to send a student back to class feeling stressed out or upset. We have an area where they can de-stress, relax, process. If they're not ready to go back, that's not a forced event. I just want to make sure you all know that we're cognizant of that. We want to make sure the student is safe at all times. Next slide. So we email the teachers, we email guidance teams, we go to IEP meetings. The really great thing about having a Zoom remote clinician is they're on a laptop and you can take them to a guidance meeting or an IEP meeting or a 504 meeting to talk about the students right under your arm. Off you go, down to the guidance with your remote clinician. So the community health worker also has a very, very close relationship with the guidance department, and also does email students and teachers weekly. If there's a crisis, we follow school protocol for crisis. The most important thing we all need to understand, and we're kind of tweaking that now since we're doing a home-based virtual program at this point, is that the school is responsible for the student when the student is there. And so we have to follow all of the policies and procedures. If the clinician feels the student is in crisis, there's a phone tree that we follow to make sure we call in a crisis response team that's going to come to the school. But the remote clinician does stay on the with those crisis people via Zoom to help the student through the process and help them take the next step to be healthy. And then also the community health worker, and this is where I need to stop and say that this program would not be as successful as it is if we didn't have our community health workers embedded in these schools. These are the key piece to this because they manage the program, they direct the program, they do all the clinical appointments, they bill, make sure that's working, they do insurance authorizations, they make sure that everyone is okay, and they are also case managing every student and their family. So these people are like, are my rock. I have an amazing team, and I have to say that without them, this probably wouldn't be as effective as it is. Next slide. So now I'm going to jump into the clinical piece here. I am not a clinician, and I'm going to say this directly. This slide set usually would have a clinician presenting because they're in this, they're in it, they're doing this every day. Unfortunately, it's summer, and many of my clinicians have taken their Fridays to enjoy their families, and I am certainly not upset about that. But I want to say, as we move into these slides, that these are anecdotal. David and I have talked about some of these slides because we are collecting data around this, but we are only in year 2 of that. So these are things that we've seen. These are things that we've witnessed. We've done qualitative work on this, just talk every week about things that were happening. So I just want to make sure you understand that this is not specifically data driven at this point. Next slide. So the clinicians are feeling, we like them to kind of think about what's the difference if you're doing face-to-face or tele, how is it different? And this is what they have given to me for that answer. They've said that they have all-day contact, so there's increased availability with the school and the community health worker. If they're needed, and there's something going on with the student, it's easy to bring that student quickly in to do a quick check-in in between appointments to make sure everyone's okay. The community health worker and the clinician spend all day together. Usually it's the Zoom is on all day and they have lunch and they hang out and they talk. They're an excellent team. And that's the key piece also to success. But the clinicians are finding that students meet their goals. They're in their treatment plan 2 to 6 months on average, which is very quick. And we're trying to figure out why, because usually a lot of times students go into therapy and they're in for 1 year, 2 years. And here we are 2 to 6 months later, we're seeing really good goal meeting or whatever. We're just seeing great results. So sorry about that, just had a minute. But we're happy about that. Students are also accustomed to the technology. And I did put this in that we transitioned just on March 16th to a home-based virtual program with the onset of COVID, but we still have 104 active students enrolled in the program. So even though we went from a school-based to a home-based, we're doing really great, and we're totally full with students. Another thing that the clinicians, wanted me to mention, that the students seem safer without a counselor in the building. I know this sounds strange, but when someone is physically present in a school, it's very easy for them to go down to guidance or go over to the administrative suite and talk about some things if they have some concerns. Here, they are remote from the school. So it makes the students feel like there's more privacy. They say there's a higher level of trust and a deeper sense of connection when working with students in this modality. Reserved students open up, and Zoom has a lot of fabulous options. We have a whiteboard, we can share music, we can have a chat feature, so students that don't feel like talking can actually just chat away with us, and They like that too on those days where they feel they need to be quiet. And the other thing we're seeing is students that are on the spectrum have a really quick connection due to the distance. They're not as comfortable with someone directly in a room with them, but this modality offers a lot of comfort. And we actually have a student who is on the spectrum that has his summer clinical, his behavioral health sessions in a dugout in a park in rural. And he's very happy there, and we Zoom him right in, and he can talk to his clinician right there in his dugout, and he's totally happy. Next slide. So here's the kind of kiddos that, here's the issues that we're seeing with our students. Being overwhelmed academically, there's perfectionism, there's ADHD, there's grieving and loss. We have a lot of students that have had cancer. We had a young man that had a brain tumor. We have another young woman that is so upsetting, but we're there for them. The cool thing about that is they don't have to miss a session, because if they're in the hospital, they can use their iPad and they can Zoom in with their clinician and be connected with them during this very difficult time. We've got family dynamics issues, and that's why we've expanded into family therapy. We have just the whole social thing of schools, LGBTQ stressors, post-traumatic stress, and then just making decisions about their life and where they're going. So those are some of the things that we've seen. And also, we also have increased communication with families and school staff, and we've seen that quite a bit. We refer out for testing and medical evaluations, though I have to tell you, I'm so excited, and I just want to share this, that Haywood is looking to bring on a psychiatric child adolescent psychiatrist. So now we will have a place to refer to directly. That's always been a challenge for our program, is finding a child adolescent psychiatrist. The community health worker and the counselor, I want to mention that. I talked about that team working together between sessions, after a session, processing, making sure we're doing the right thing for students, having the community health worker follow up with social skills work until the next session, and checking in. So we've got on that. All righty, next slide. So these are the improvements that have been observed but not data quantified, but I really wanted to share this because I think this is really key and why we do this work. It's not about me, it's not about the program, it is about our kids. When it stops becoming not about our children, then we have to relook at what we're doing. So this is the slide that makes me most proud of our clinicians and our community health workers. We have seen increased school attendance. We've seen improved academic performance, improved family and social relationships. Positive behaviors are happening. Self-esteem and self-confidence are increased social integration, and we've eliminated self-harm and provided safety for our students. So with that, how can this not be a success? And I don't know, I'm not gonna vector too far away, but I've been an educator for 20 years, and I have seen how important behavioral health is for our students, because as a teacher, I was supporting them and seeing everything that they go through. So this is just amazing to me that we can do this work and make this happen. Next slide. So I just wanted to talk a little bit about COVID and how our life has changed a little bit since March 16th when the schools closed. We transitioned from, and I have to read this because it's kind of a long word here, we transitioned from a school-based program to a home-based virtual program with specific guidelines to assure HIPAA, FERPA regulations and privacy expectations. Now, how's that going? Well, we're trying to have parents support and sibling support, that when it's time for a clinical session with a student, that they have a private space to go. Students, a lot of times, because they're older, will go find private spaces themselves. Just recently, last week, one of them was taking their clinical session in their bathroom. with the door locked so they'd have privacy. Another was out in their car. And like I say, I have my young man that likes to go to the dugout. And you know, they are doing what they need to do to have their sessions. But it is different because they're not within a brick and mortar situation right now. So we are having to track them down more, and we've all had to remind them more and make sure. We do have a little higher tick of no-shows now, but we're working on that. The community health workers are working remotely now as well as the clinicians, but they check in with students via Zoom just as much as the clinicians do. So that's all working very well. Our virtual, now all our intakes are virtual. We use DocuSign with all our families, and that seems to be working fabulously. We have a current census of 104 students and in our 3 school districts. So I'm very proud of that. And most of them are coming to sessions. Our treatment as usual school now, thankful to my HRSA project director for understanding for us, is that they're receiving tele, because we know ethically and morally what those students ICD-10 codes were. We knew their diagnosis. We knew we had to make sure they were allowed to have these sessions also. So the treatment as usual school is now having the opportunity to refer students to us, and they are doing so. September, a return to school is going to look very different for the state of Massachusetts. I don't know if you know our numbers right now. We have over, I don't know, maybe up to about 105,000 people infected. We have had over 9,000 deaths from this virus. School is going to be very different. The talk right now is that there's going to be 20% of students in the school Monday through Friday, you know, X amount of students on Monday, Tuesday, Wednesday. And so we're looking to, with tele allowing us to be flexible, we'll probably be having their sessions still home-based, so as not to pull them out of their school classes when they are actually there, because that's going to be critical, and we won't be doing that. And then we also have seen, you know, on the other end, that we have increased revenue due to tele coverage with Medicaid / our Mass Health and private insurers. They said they would cover tele now, so actually we are getting reimbursed better at a better rate, which is pretty wonderful, because prior to that, that wasn't so, that wasn't happening as well. So it's not a great thing, but in terms of our program and having to be able to increase our revenue and think about sustainability, it's helped us. Next slide. Now I'm going to mute myself, and I'm going to turn this over to David Robinson. And I want to say one thing about David before, and he doesn't know I'm going to say this, but he has been our rock in this program around data. When you're me and you're not a lover of data to start, and then you become a lover of David, a lover of data because of David, then he's done his job. So I just want to introduce David, and I'm going to mute for now. Thank you.
Gee, thank you, Maureen. That was very unexpected, but I'm pleased to hear that sometimes an evaluator can get through to a program manager and program director. Yeah, it's amazing to be an evaluator at this time. You know, earlier I mentioned it's both the evaluator's dream and maybe his nightmare all at once, being the evaluator on this program, not because of the staff certainly, but because of conditions outside of anybody's control. And that's not atypical for many evaluations. They can be very messy. But let me tell you a little bit. I'm, as Maureen said, David Robinson. I'm a retired professor from Simmons College, and now work for the Northeast Telehealth Resource Center, and am the local evaluator for this project. There is a national evaluator as well, the National Rural Health Research Center under Marcia Ward is conducting a national evaluation, because there are many more sites. And Whitney Wiggins has reminded me, but I can't remember how many sites there are, but across the country, trying to demonstrate the benefits and outcomes of telehealth across the country. So in this project, we had to come up with a evaluation design that would give us some rigor to identify clinical outcomes and improvements in students who needed behavioral health, and to design it in such a way that we had both schools that received the intervention and schools that received the usual and customary way of face-to-face type of behavioral health. And so we were able to, with Maureen's help and the community health workers' help, Athol Hospital and others, we were able to come up with schools that were somewhat similar in their population. In terms of the rural health, we realize in all this interest now in the country on racism and on the cultural identity, in rural schools, majority of the students are white, and that's also reflected in the data that we have for these two schools, but for these two conditions. Nevertheless, we were able to do that and convince a school, Pioneer Valley, to convince them to serve as our treatment as usual school, with the option of receiving telebehavioral health at some point in the future. So we, on a quarterly basis, and I'll say a little more shortly, a little bit about the kinds of data that we're collecting for the national evaluation, and I'll also describe in a little more detail shortly the kind of data that we have locally as well. We send quarterly to the national evaluator in Iowa. We send them a data file, which is very carefully reviewed by our community health workers and by Maureen before we send it out to them, encrypted. So they have the data, and they carefully send back to us a review of that data. So if there are any errors or any problems in the data, we can go back to our original data collection forms and make sure that we've incorporated and edited and made the changes that are necessary. So there's really good checks and balance on the data that's being collected. Now, I did say that while it's a dream to be an evaluator with this team that is, unlike what Maureen said, very data savvy, and for them it's very important to document their work. The community health workers are, and I know Maureen has said this, are the part of the dream team here, because they have contributed to the local collection of very detailed collection of encounter data, which is then used to enter into our national data set. So we always have that local worksheets to go back to if we need to check data. So data quality has been important right from the beginning, and that's part of an evaluator's dream, to have a team that will work with us and collaborate with us in that way. Next slide, please. So I said that our evaluation outcome measurements are fairly sophisticated. They were developed over a fairly long period of time, and our initial data collection, while we had almost a year of planning ahead of time, our initial data collection efforts included these 4 primary outcome measures for clinical outcome measures. So we wanted to know something about the mental health, the general mental health characteristics of our populations, in both groups, the physical health and the global health. And so we use PROMIS, which is a well-researched tool with good reliability and measurement, and 3 subscales from the PROMIS, which is fairly applicable across not just the school-based programs, but across other kinds of telehealth services. Adolescents come with a variety of symptoms and clinical problems, including anxiety, including depression. So the generalized anxiety scale, the GAD-7, and the depression score from the PHQ-9 are also used and reported on. And then the DUDIT substance abuse severity score for students with substance abuse issues. So these are the primary clinical outcome measures that are collected and reported on by our community health workers and by students. Some students fill out on their own, some our clinicians administer. Now, there are other kinds of important differences in conditions. We are very concerned with the quality of our care measures. And so one of the ways we would track differences across the treatment as usual and the telebehavioral health would be to understand the difference between the time of referral for behavioral health services and the time of the intake and the meeting with the first appointment with the behavioral health specialist. And of course, our clinicians and all use a standardized screening tools and approach for the initial screening of our students, Also, we will be able to then analyze and report on encounter timing, the duration and completion of data. We'll have some data on the distance to usual treatment resources. And we have the medical database through the Haywood Healthcare database, the associated costs and income from billing. So we'll be able to say something about cost effectiveness of the telebehavioral health approach. Next slide, please. Yeah, before I report on overall numbers here, I want to say something about the local data as well. We have also included, but not reporting at the national level, we have included satisfaction surveys for students, parents, and for school staff. We did a survey initially of our community health workers, especially around some of the changes related to their activities as a result of COVID-19 and its changes to the school environment. We also will have some interviews of a sample of parents and school staff coming up shortly. And I want to again call attention to the detailed tracking worksheets that were developed with the help of the community health workers with the detailed encounter information. And you can see our numbers, 2,900 plus sessions completed between January and May 2020, January 2019, May 2020, and 164 total students served since January 2019 and May 2020. And with that, that's all I'm going to say now. I hope we have some questions, but I'll turn it back over to Maureen.
Hello, I am back. Here's where you can find us. You know, I know that Reed is going to make sure that, and any TRC will make sure this PowerPoint is available, so you'll be able to reach us anytime. I really, really want to impress upon you that it would be absolutely wonderful to reach out. I mean, we are a HRSA funded program. We're here for you. We are sharing all about, you know, what we're doing, how we're doing it, what our forms look like, what our data looks like. So if you ever want anything, please give me an email and I will be there for you to help you out.
Okay, so we are ready for the question session. I will say that kind of concurrently here, if you folks could, I'll just point this out and I'll bring it up again, but I don't want to shortchange the question time. The session feedback is directly underneath the information that you found to get onto this event. And you'll also be able to find the slide deck there as well. And so by saying that, hopefully I won't have to say it again. I did see a hand go up. I believe it was Jennifer Gordon. And so Jennifer, you should be able to unmute yourself and ask your question. Feel free to turn your video on as well if you'd like to. Any, Jennifer's having a little bit of an issue unmuting maybe. So do we have any other folks that would like to, so you raise your hand by clicking the participant tab. And then there's a button there for you. It's not there for me because I'm a panelist, but there's a button there for you as an attendee to raise hand. And that'll allow us to know that you'd like to be unmuted to sort of learn a little bit more about that. I'm speaking for them a little bit, but I would imagine any question is, oh, there we go. Perfect. Can you please talk about your plan for sustainability?
Absolutely. I'm excited. We are looking at possibly starting maybe in January to expand the program to work with Haywood Health Systems partners. So besides being school-based, which we are going to stay, those are like one prong that will be school-based, and we're actually expanding to other school districts. As a possibility there, we're looking at that. We're also looking at expansion. I said a second prong, so looking at all of our Haywood healthcare partners, all our family health centers, all our emergency departments, to actually have a team assigned to them to work with adolescents and being referred through pediatric offices also, as well as other partners in our system, because I think that that would be very valuable for us because this is working so effectively. And then also the other piece is bringing in the psychiatry piece, which would allow us to have, be able to do medical med checks and all of those things with our kiddos that is greatly needed at this point. So we are looking at expansion, and we are looking at very seriously, we started billing September 1st. So we know our numbers around that, and we're not quite sure how that's going to roll out, but I want to look at the 1 year numbers. So I want September 1 to September 1, and that's going to let me know what revenue can cover the positions that we have and see and work toward that. We also want to come up with a business plan or a business model for telebehavioral counseling and the telebehavioral health program to present that to the senior team to see if it's something that they would want to consider. Right now, at this point, it's looking very positive that this program will be continued post-grant, but I can't say definitely, but it's looking very good. So that's my plan. It's not a specific plan yet. We haven't written it all out and had it all, you know, but it is, we're thinking and developing our next steps currently.
Here. Okay, Maureen, the next one, or David, either one actually. The next one, you can see it up here. Are you capturing provider feedback or preference on tech considerations? And I'll add my own little personal question in here as well. Both like the interaction, but also the tech modality. So like cell phone video versus laptop.
Good question. So our satisfaction surveys do ask a series of questions of providers, including questions about their use of technology and the particular platform that's being used. And I'll have to look at, to be honest with you, top of my head, I can't remember all the specific questions, but I will pull it up later, maybe make it available if anybody has any questions about it. I think it's a good question to ask about cell phone and laptop or iPad or pad or whatever they're using, tablet, and we will be able to get some kind of feedback around technology use by our providers through the satisfaction surveys.
Awesome. Thank you, David. I think that's great. I think that's really important stuff. I know I would be interested in it, but I won't give you any more work than I've already asked you guys to do to be here today. So let's see if anybody else would like you to perhaps provide that in your profile on the event, which I think would be very informative. We've got a few more minutes here. Does anybody have any other questions that they'd either like to populate into the app or unmute yourself and ask? I know a lot of the names in this call, and I know you're not shy people, so I'd love to hear from you. And I think David and Maureen would as well.
I would love to. I do want to say, Reed, though, I'm going to back up on that issue around tech considerations. You know, when we first implemented this, we went through a bunch of kind of some bumps, right? Getting this into schools, getting it where it needed to be. And one of the issues was that at lunchtime in schools, kids are allowed to use their cell phones. It totally crashes the internet. So we realized that at that point, when we were at school, we had to, you know, not have sessions during lunch because it was just not going to work out so great. Also, now that we're in homes, believe it or not, out in rural, a lot of people still don't have internet, right? So we've using MiFi boxes with some students. We've talked to Spectrum and have asked them to bring free Wi-Fi service to some of our needy families, which they've done. So you just have to be creative around that, and we try to be the best that we can.
I think those are both really powerful insights. I do. I think that's very true. And the lunchtime thing makes sense the same way that I'm sure all of us have noticed it around 4:30 or 5 that your Zoom links and your Zoom meetings and whatever platform you're using gets a little slower as some folks hop on Netflix and other things.
I also want to add one thing too, and that is that, you know, the use of a platforms or the use of the devices is somehow, I think, constrained by privacy issues as well. How do you, you know, the more easy use of a phone makes it more likely to be in an area where other people might be able to hear or not hear. So some of those issues are determined by the kinds of, I think, by the kinds of secure private locations one can develop for whether it be in the home. Maureen might want to say more about that, or out in a playground.
Right. Yeah, some of our students, I think some of our students that were over 18 and did their own intakes and had controlled their own, you know, their phone, or they were very, that's what they used. They used an app on their phone with Zoom to have their sessions. But most of the time they have their Chromebooks, especially now they still have their Chromebooks at home. That's directly, you know, they have a school policy around those. And so, you know, but it is, I have to tell you, now that we're in homes, we're seeing a lot of things we've never seen before. And we have, you know, photo bombs by younger siblings, and that's why they have to go somewhere private. You know, we have to really, one of our students was in session and decided to jump in a car full of other high school kids and take a joyride, and we had to cut the session down because that's not privacy and we can't be doing that. So in all honesty, you know, there's been some challenges, and we're capturing those and just sort of thinking about what's the next steps around this, because this is all very new too, right now with being home-based. So.
I'm not sure about this question. Reed, do you want to read it out loud? I'll read it, and then I will. I know Jan's still on the call, so we can always ask her to tell me if I'm sort of adding on to it incorrectly. But I think, so the question is suggestions for bridging educational institutions and medical ones. And I will say that I'm like, obviously you had the grant to help you navigate some of these relationship buildings, but I think there's a lot that can be learned about some of the people or the roles that you had involved in your conversations, and some of the infrastructural and logistical considerations that you guys have had to implement.
So I love this question. So there's me, because I have to tell you, I was a teacher for 20 years. I never did medical. I never understood hospitals, organization. I have to admit it, right? So they put me in this position for this reason. I understood schools. I learned about healthcare and what their expectation was. And then we had a third party, because we had a behavioral health program that we hired our clinician with. So we had 3 different systems trying to play well in the sandbox. And that is not easy. And I have to tell you, you have to understand where people are coming from. You have to be respectful of that. We have something called Teleteam Partners. It's all our school partners, all our hospital partners. We all meet together. We talk. We have open communication, transparent communication. If things are tough, we work it out. I have to tell you though, that first grant showed us that we needed to hire our own clinicians instead of using a different, behavioral health center, because it just worked better, because those clinicians now were working under our policies, our procedures, our behavioral health procedures that all kind of worked well. And then we had a lawyer look at all the forms. We had to look at HIPAA and FERPA, not just FERPA is the school-based, that's their HIPAA, right? So we had to combine things. We had to look at how we could all work together. So that is what we did. And you never give up on that. I mean, just because you're a different system and you come from a different place doesn't mean you can't get together and work together. And yeah, maybe there were some bumps with superintendents, and maybe they weren't sure about the memorandums of understanding and they wanted to make sure that they understood, and we had to sit down and talk. But that's the key piece in this, is that type of communication. And before I did this work, I developed a coalition. And so I understand difference in people, and I was very comfortable with that. But I think it's key to have someone who understands schools as well as understanding the medical piece, because then you can respect each other and where they're coming from. So,
Don't you? I also want to say, I think there's a lot to be learned from, say, after middle of March, when suddenly no one could even go to the doctor's office or visit the school, and schools just closed. We're going to learn a lot now nationally from what's happened. All of my visits to my doctor are through telehealth encounters, and I'm sure that's happening to all of you as well, or many of you as well. So there's still a lot to learn, but I think we're going to learn a lot over the next quarter or so.
Awesome. Thank you, guys. And Jan, I think actually has a follow-up question. So I've tried to unmute her, and she should be able to join us.
awesome.
Can you hear me?
Yes.
Yes.
Perfect. Thank you guys for presenting this. I'm a developmental pediatrician and work with kids with medical complexity in New Hampshire, and we're pushing in with schools. And I think your input, it's a different way of doing it. I look forward to seeing the forms that you've developed and just appreciate how you've approached it. So thank you very much for your help. Do you have any other medical specialists pushing into this, or it's around mental health rather than like developmental peds or other things?
We don't, but I
That's
know
almost
there's
a Whitney Wiggins question.
I know that's always our project director question, because there's only 14, but they did have a school-based telehealth grant prior to ours for 4 years, I think. And they have some data around that, and they have some information about what types of programs that they've implemented. We actually have 2 school-based health centers, and we're thinking about possibly doing some telework there now, because our schools they're not there, but actually sort of transitioning those a bit. So I think the medical piece, our medical director for HAMG, the Health Medical, Haywood Medical Group, is really looking into using tele in lots of different ways. They haven't included me in that yet, since this is sort of my focus right now, but I am being brought in to talk a little bit about that in community-based settings, how we can move this forward a little bit. So, and you're right, North Carolina has a fabulous school-based telehealth program, and I've looked into that and have actually researched that, and they're wonderful. So just saying, I'm gonna say yay to that too.
Hey, Maureen,
I
maybe
did-
we could
got
ask
unmuted.
Maureen,
say that
maybe
again?
we could ask Whitney about some of the other medical specialties in some of the other telehealth sites.
Right. It'd be awesome. Just email me, Jan, too, if you want me to share those forms with you, what we have, I can do that. So, please give me a quick email and I'll send them your way.
And folks, we actually, so Renee, I did mean to unmute you, and you are welcome to stick around and ask your question or add on there. I have scheduled this Zoom for a few more minutes to allow folks to kind of transition ask one or two more questions from Maureen and David and do as they please. But we stuck right up on our time here. Thank you all for joining us. And Maureen and David, thank you again. That was a wonderful presentation. And then the question and answer session. I mean, that was just a really very cool discussion.
Thank you so much. So thank you.
Thank you very much.
Oh, hey, it's Renee. I actually didn't have anything more to say, just was gonna give you that information.
Right. Thanks, Renee.
Thank you all.
Awesome. Okay. Well, I mean, so I'm just very, very grateful for Maureen and David's time. And for those that were able to ask some questions. I think we had a great conversation here. It should require nothing more than you hitting leave meeting at the bottom of your screen to go back to the platform. You should have about, if I had the right paper in front of me, I'd be able to tell you, about 15 minutes to do a virtual stretch session to watch one of the vendor interview panels, or to stick around here if you'd like. We will be able to do so for that amount of time as well. And then I'll have to run to my next session.